This webcast and any accompanying materials are copyrighted by the American Association for Respiratory Care. Any public display, sale, copy, or distribution of the video or materials may only be undertaken with the prior written consent of the AARC. Copyright 2016, all rights reserved. My name is Shauna Strickland. I welcome you to today's presentation. Pulmonary Rehabilitation Outcomes. Achieving Measurable Outcomes in Pulmonary Rehabilitation. Upon completion of this AARC webcast, participants will be able to discuss competent performance of measuring functional capacity, describe 3 evidence-based outcomes in pulmonary rehabilitation, describe cost and interpretation of 3 outcome tools, and identify 2 options for tracking and reporting outcomes. I am very pleased to welcome Ms. Chris Garvey. Ms. Garvey is a nurse practitioner at the University of California, San Francisco Pulmonary Rehabilitation and Sleep Disorders Center. She has authored and contributed to several original publications in the field of healthcare utilization related to pulmonary rehabilitation and chronic diseases, including COPD, asthma, interstitial lung disease, and sleep apnea. Ms. Garvey has no relationships relevant to this discussion to disclose. I disclose that I am a paid employee of the AARC. Brand names of products and/or medications may be mentioned only as examples of technology. Any use of brand names is not in any way meant to be an endorsement of a specific product, but to merely illustrate a point of emphasis and to provide information and education regarding the availability. Chris, welcome to the program.
Thank you, and thanks to all of you for taking the time to look at outcomes in hopefully a fairly careful way. I may have to ask your help with advancing the slides. I'm not seeing the slide deck. I just see they're perfect, and I'll say advance when I need you to go to the next slide. So today we'll be talking about pulmonary rehab outcomes. I know many of you work in pulmonary rehab and have had experience with outcomes. I'm going to focus today on what are the commonly used outcome tools, how to use them, how to interpret them, and also what's new from an outcome measurement standpoint. Please advance. Please advance the slide. I have no disclosures related to this topic. Please advance. So we'll be looking at, again, why use outcomes? We want to understand and measure the effectiveness of the service we provide to patients, not only from a quality standpoint, but to demonstrate to our patients, our referral sources, and administration that we're improving care and improving outcomes, improving function, symptoms, hospitalization, many of the important benefits of participating in pulmonary rehab. As you know, if you've read the Medicare requirements for pulmonary rehabilitation reimbursement, they're very specific about patient-centered outcomes that are measured before and after pulmonary rehabilitation. In fact, now there's a suggestion that if the mood disorders or depression or anxiety rating is elevated, that it may need to be measured midstream. So quite a bit of requirement. Also from Joint Commission, there's a requirement for measuring outcomes. Some of you may be certified by AACVPR or be interested in certification. The certification has specific outcome measurement requirements. I strongly suggest you look at the application early on in your interest in getting certified because it changes every year, and that's available on the AACVPR website. I got interested in outcomes from research, but it's important for patients to know that we expect them to improve, and I tell them that. I tell them how much the average improvement in shortness of breath and function is in my aggregate or global population. There's no guarantees, but when they know that there's an expectation they're going to improve, I think it encourages them. Also, at the end of the program, I go over the details of outcome measurement and where they've improved, and they find that as well reassuring. So where do you start, or what do you use for platforms? I've been doing this for a bit over 20 years, and I, for the most part, have used an Excel spreadsheet, which works very well. AACVPR has a registry that can support not only outcome entry or data entry, but clinical information and demographics, and also aggregate and report for the patient and administration and referral sources all of the outcome measures pre, post, and 6 months following start of care. And I'll talk a little bit more about the registry when we finish the presentation. Next slide, please. So today we'll be talking about outcome tools, what's new in particular, and use and interpretation. We'll look at functional capacity, focusing on 6-minute walk test, and talk about some considerations for measuring physical activity, talk about symptoms, specifically dyspnea, health-related quality of life, and then psychosocial evaluation, focusing on depression and anxiety. Next slide. Now, the 6-minute walk test, this is a test that's used by many of us. I suspect the majority, if not all of us, use this normally pre and post pulmonary rehabilitation to measure physical activity. Very important part of this. You'll see two references at the bottom. Ann Holland and Sally Singh, along with their colleagues, updated all of the evidence related to performance and interpretation of these tools. Please go to the ATS website. It's www.thoracic.org. Look into statements. And in the statements under pulmonary function, you'll find both of these resources. They're lengthy documents, but I think it's really worth your time to review them. They're very important, and there have been some changes that I'll summarize today. So they update the evidence, the protocol, interpreting the test, and how to perform it safely. They focus solely on chronic lung disease in adults. We know that decrease in functional capacity, specifically 6-minute walk test, is associated with increased mortality in COPD and increased hospitalization. And we know it's responsive to treatment, particularly in pulmonary rehabilitation trials in COPD, interstitial lung disease, and pulmonary artery hypertension. Next slide, please. So where do you start? You start with reviewing the patient's record and looking for absolute contraindications. These are primarily cardiac, but really any disorder that would affect the exercise performance or be aggravated by exercise. Probably the most common one we encounter in rehab is hypoxemia. Certainly if they're hypoxemic at rest, they will be needing oxygen. You're not going to use the 6-minute walk test for titrating oxygen. You can do a 6-minute walk test and titrate, but you wouldn't be using that specific test for measuring distance. Distance needs to be measured with the oxygen flow rate being consistent and not change during the test. So you would titrate the patient before the 6-minute walk test. Next slide, please. So these are relative contraindications. So for these particular clinical problems, you would discuss these with your medical director before you would perform a 6-minute walk test. Some of them, such as untreated severe hypertension, would need to be managed before the test. Tachyarrhythmias, bradyarrhythmias, some cardiac involvement, significant pulmonary hypertension, which we often see in pulmonary rehab. So the medical director needs to be involved before you perform the test. Any orthopedic impairments that would prevent walking are important. So clinical instability. So these would need to be considered before you would proceed with a 6-minute walk test and optimally stabilized before the test is performed. Next slide, please. So equipment, and all of this is outlined in detail in the documents I referred to. So I think they're an excellent resource for you to update your performance of the testing. So the equipment would include at least one chair, and this is if the patient needs to rest during the test, a blood pressure cuff and a stethoscope, and a functioning oximeter. And when you're measuring O2 sat during the 6-minute walk, you're not having the patient hold a handheld oximeter. You're either using a finger ox or you're putting the handheld oximeter in a pouch with a window where you can see the O2 sat during the test. You'll have a stopwatch and a clipboard. You'll have portable oxygen and some type of stroller or a way to transport it. You need to have telephone access in case there's an emergency. You need to be using a valid dyspnea scale, such as the 10-point Borg dyspnea scale. We'll talk about that in a minute. A track or hall. This is where a lot of programs get challenged because they don't have a long enough hallway. It needs to be at least 30 meters, so approximately 97 feet long. Problem is, if you have a short hallway, patient keeps turning. Those turns decrease the overall distance they're walking because you have to spend a couple of steps turning. So it should be pre-measured. Big emphasis on accuracy. You're not eyeballing the distance they walk. You really want an accurate measurement of the corridor that you're using, please. Accurate. The 6-minute walk test should be as reproducible as a pulmonary function test. So that's the underlying principle. And then an emergency plan if the patient deteriorates. So what about protocol? This is new. So the recommendation is the initial walk should include 2 walks. The reason is there's a significant learning effect with the 6-minute walk test, meaning that the patient varies quite a bit in their first and second walk just based on learning how to do the test correctly. So you would do two initial walks and use the best of the 2 for the reported walk. If the patient has subsequent walks in pulmonary rehab, you don't need to do 2 walks unless it's been several months. They don't give a time frame, but you would consider learning effect as the important determinator. So you're going to be measuring their O2 sat continuously. You want accurate signal quality from the oximeter. You're going to rate their dyspnea with a validated tool and their fatigue. And then at the end of the test, you're going to report their oxygen saturation nadir. So it's not the O2 sat at the end of the test. It's the very lowest O2 sat during the test. And then the end heart rate. You don't walk with the patient. You don't help them to walk. You don't walk in front of them. You walk behind them. You do not want to influence their walking speed. If they ask you how fast they should be walking, tell them you need to walk. You need to cover as much ground as possible. You need to walk as far as possible during the test. You can't tell them how fast to walk. That's really up to them to decide. During the test, you want to be sure to keep constant the staffing, the setting, the oxygen system, including flow rate and transport, and their usual walking aids. In other words, keep everything consistent so it's a very reproducible test. It's not the easiest thing for all of us to achieve, but important. So if I did a 6-minute walk test in San Francisco, and then the patient went to New York and had a second one, it's difficult to compare those two because there's so many variables. Next slide, please. So the protocol, before the test, the patient takes their usual medication. They can take a bronchodilator, but document that. They should be wearing comfortable clothing and appropriate shoes. No vigorous exercise before the test, so you wouldn't have them perform their pulmonary rehab exercise and then do the 6-minute walk test. Do the walk first. The pre-test measurement, O2 sat, heart rate and blood pressure, dyspnea and fatigue at rest. And then they use their usual walking aids, and you document that. If they stop during the test, you want to record the number of stops, but most importantly, the total length of time that they stopped. For oxygen, again, keep the flow rate constant throughout the test. Ideally, they should either carry their oxygen or it should be rolled. There's no clear direction on whether it needs to be continuous or pulse or intermittent, or if it's their own system or your system. That is not specified in the statement. And again, don't titrate oxygen during the test. That's a separate test. Next slide, please. So when do you stop the test? At 6 minutes. However, if they deteriorate, you stop it sooner. So the statement says you need to stop it if their O2 sat goes below 80%. Personally, I stop it if it's around 84, 85, because I think they are probably going to be trending down if they're that low. But 80 is the absolute lowest. If they have chest pain, if they have intolerable dyspnea, if they start to have leg cramps, if they're staggering or diaphoretic, if they become pale or ashen, so clinically unstable. If they stop, the patient should either sit or lie as appropriate. Certainly if they're dizzy, you need to let them sit down and lie down if sitting is not appropriate clinically. And then obtain, based on your judgment, their blood pressure, their heart rate, their O2 sat, physician evaluation, if appropriate, and oxygen is needed. So you need to have a protocol of how you're going to handle this. Next slide, please. So this is a script. I'm not going to read it to you. I've highlighted some of the key features, but I would like to encourage you again to download the statement and to read the script. Consistency and reproducibility is very important. So this is something that you want to basically read to the patient word by word so they understand exactly how to perform the test. So I am going to refer you to the statement, but I think you get a sense of what the message is. It's directing the patient exactly what's expected of them during the test. Next slide, please. So this is standard encouragement. So you shouldn't be saying, you know, go a little faster, you're going too slow, doing a great job. That's encouragement of one kind or another. You should follow the script. You're doing well, you have 5 minutes to go, keep up the good work, you have 4 minutes to go, etc. And then stop them at the end and ask them, how short of breath are you on a scale of 0 to 10? And I would show them the scale so they remember what you're asking. Next slide, please. So interpretation, once you've done the 6-minute walk, what do you do with it? Well, you're measuring the distance walked. That's the primary outcome. So looking at outcomes, there's a term called minimum clinically important difference. And what that means is, at what point does the patient feel a difference, either of improvement or worsening? So this has gone back and forth for years for the 6-minute walk test. It's a very common test in pulmonary rehab, but also in drug trials and other research studies looking at lung disease. So currently, the mean minimum important difference is 30 meters. What does that mean for us in pulmonary rehab? It means that maybe not every patient on 30 meters, again, is about approximately 97 feet. So you might not have every patient improve that much, but your aggregate or your total patient population should be improving that much. If not, you may want to look at your exercise prescription protocol and what possibly might be hampering that. If you're seeing all patients listed for a lung transplant, they may be too sick, but you want to consider that. 30 meters is the MID for chronic lung disease improvement in pulmonary rehab. So to convert it to miles per hour, the equation is here. It's 6-minute walk distance in feet times 10 divided by 5,280. Now, some labs, particularly pulmonary function labs, use a reference equation of what's the predicted 6-minute walk distance for a certain age or gender. There's 7 different methodologies cited in the statement. There's quite a bit of variability. If you use this, you have to describe which one you're using, and also try to understand, has that method been tested in the population that you see? So it's got some considerations when you're using it. Next slide, please. So physical activity, we're still evaluating and trying to understand what is important. What's the best approach to physical activity? We haven't quite solidified that, but we do know that measuring physical activity is important, and there has to be physical activity and exercise following pulmonary rehabilitation, or the benefits disappear quite quickly. So this is something to talk to patients about early during the rehab program so they have a system in place when they graduate. So pedometers do increase motivation to walk. The Fitbit is a popular tool. This is a picture of President Obama with the Prime Minister of Ireland, and he's got his Fitbit on. There's lots of devices available. They have been validated in research in chronic lung disease, so it's a reasonable option if the patient thinks it would help them. There's two other devices identified here, the Omron activity monitor and the Yamox Digit Walker. It's tricky using a pedometer in slow walking COPD because it doesn't pick up all the data. The Fitbit is a little bit more sensitive. Some people use an app on their smartphone. It's not perfectly accurate, but it is good for trending. So if that's a good system for the patient, at least it will help to improve their awareness of how far they're walking based on using the GPS. Next slide, please. So let's transition to the symptom of dyspnea. This is a question that you'll get a chance to answer. I'd like to know which measure of dyspnea are you currently using. You can take a minute to look at that. You can answer more than one. And while you're answering, we'll go on to the next slide. Okay, so I suspect that many of you, if not all of you, are using something called the Borg Dyspnea scale. This has been around quite a long time. This is from Dr. Gunnar Borg, I believe out of Copenhagen. So this is like the 6-minute walk test. This is a tool that's been updated. And Dr. Borg has made some important changes for you to be aware of that are new to many of us. So there are updated requirements for use. And I'm referring to the Borg 10-point scale, but I'll talk about the other ones as well. The CR stands for category ratio. So it does require author permission, and I'll give you the information to access that. The scale normally is subject to a fee from the user, so you have to go on the website and find out about that and determine what level the fee would be. I understand that many of you have accessed this from perhaps a CVPR or ATS in the past, but this is a change, and he's the author, and he's copyrighted it, so it's something important to be aware of. We've been in direct communication with him. It's very important to him that you understand and accurately follow the instructions for use. And also, very importantly, the modified Borg scale is not an acceptable substitute. So Dr. Borg did quite a bit of testing on this scale when he developed it. He never tested anything called the modified Borg scale, so that is really not the current scale. He's reached out to ATS, ACVPR, to clarify and help us work through this change. So you'll see resources on the ACVPR website that would support this. And we have a toolkit available. It's called the Pulmonary Rehab Outcome Resource Guide. If you're an AACVPR member, we're updating that, but it's got clarification on all of this on the website for your review. So the Borg scale measures intensities of most experiences in determining perceived exertion, specifically dyspnea and fatigue. It's nonlinear and somewhat positively accelerated growth functions. So it's actually, even though it looks like a simple scale, it's actually not simple. It's rather complex, but important and very well validated. Next slide, please. So it's constructed to grow linearly with workload. So it grows with increase in heart rate and oxygen consumption during comic aerobic tests of functional capacity. This is both the 10-point scale, the RPE scale, so they both have that capacity During the test, you're going to ask the patient how strong the feeling is before the test, and then about 15 seconds before the workload is increased, and that would be using an exercise test such as a cardiopulmonary exercise test or the shuttle walk test, and then you would do it at the end of the test. So this is your resource for getting updated instructions, the tool, and also finding out about permission and any cost. So the website is there for you. It's borgperception at telia.com, and there's the website. Sorry, the first one is the email. The second one is the website, www.borgperception.se, and there's a European phone number available to you. So those are your resources for finding out what's needed to use the tool. Next slide, please. And this is a long list of resources. I don't expect you to remember this. This is all available on the AACVPR website. It's, again, quite lengthy, but the first one is really the important one to consider and use. Next slide, please. So on to another tool for dyspnea. So this is the Modified Medical Research Council Dyspnea Scale. It was developed approximately 60 years ago, used for measuring disability in COPD. There's two versions of this. This is the one that's most commonly used, the 0 to 4 scale. There's also a 1 to 5 scale, but this is the perhaps more preferred one. I want to point out number 3 uses meters. So if you're currently using 100 feet, you need to adjust it. That's an inaccurate change in the test. So this measures shortness of breath in common daily activities and exertion. Next slide, please. So it describes activity-provoking dyspnea and impairment. It's very simple and standardized, been used for over 60 years. There can be underestimation bias if the patient is avoiding exertion. So they may not walk with other people. They may not be able to respond accurately. It's got a low sensitivity to change, and that's because it's only 5 points, so they can only change so much from an intervention. It lacks precise limits, so it's a bit general in its description, and there's scarce data validation because it's been around a long time. In terms of responsiveness and sensitivity, the data really isn't there, but it's very commonly used and rather easy to use. Next slide, please. So this is a much more robust scale called the University of California, San Diego Shortness of Breath Questionnaire. This is looking at 24 activities of daily living and having the patient rate their breathlessness. It's a 6-point scale. So the patients are asked, for example, how short of breath do you get at rest, while eating, while dressing? You need to instruct the patient if they don't perform the activity, they need to estimate the rating. Now, in San Francisco, if you've been to San Francisco, you know the residences rarely have lawns. It's like Manhattan. So there's a question about mowing the lawn, a question about washing the car. So there's questions that may ask patients activities they don't perform. So be sure that they understand they have to estimate if they're not performing it. It's very easy to administer and score. It is copyrighted. Translations are available at mapi-institute.com, so a good resource for a lot of outcome tools. And you interpret it, it's a 0 to 120 score, higher scores, more shortness of breath with ADLs, and a 5-point change is considered to be the clinically significant cut point. It's considered highly reliable and valid. Next slide, please. So the next tool I want to talk about is called the Baseline Transitional Dyspnea Index, or BDI-TDI. As you can imagine, this is a scale, a tool that rates shortness of breath at the patient's baseline and then over time. So the baseline dyspnea index rates dyspnea at a single point in time on a 5-point scale, from 0, which actually is severe on this scale, to 4, which is unimpaired. So the range is 1 to 12. And then the TDI you might measure at the end of the pulmonary rehab program is a different scale, 7 points, and the range is from -3, which is major deterioration, to +3, which is major improvement. Next slide, please. So this significantly correlates with dyspnea measurement, quality of life, and shortness of breath with activity. It's considered valid and reliable when compared with pulmonary function. 1 unit has been described as the minimally important difference. It is free to non-funded research and individual clinical practice. Next slide. So outcome tools. These are 6 tools that measure outcomes. 5. So the St. George Respiratory Questionnaire, I'll talk about this. That's kind of the mother of all quality of life measures. And the Chronic Respiratory Disease Questionnaire, that one is licensed and has a fee. The CAT test, which has become newer, it's from the author of the St. George Questionnaire, Paul Jones, becoming quite popular. The Ferens and Powers Quality of Life Index, and the SF-36, which is licensed and it requires a fee, and then finally the Dartmouth Primary Care Cooperative. Next slide, please. So the next question is, I'm going to ask you, which of these are you currently using? Any of these tools or other? I'll give you a few minutes to answer. And while we're getting an answer to that, I'll go back to the dyspnea scale. So in terms of using the 10-point scale, 38% reported they're using that. 24% reported they're using the modified scale. 10% are using the RPE scale. 5% are using the MMRC. And then UCSD, 2%, and then other 21%. So a rather broad range, and I hope that the discussion of the Borg index was helpful in that regard. All right, so let's talk about the St. George Respiratory Questionnaire. In rehab, but also in drug trials and research trials, this is really the most common tool for measuring quality of life. You do need to get permission from the author, from Paul Jones, and hopefully you can see his website at the bottom, healthstatus.sgul.ac.uk/SGRQ. And you can actually do a search for SGRQ. Paul Jones is the author, and obtain that information. So the score is 0 to 100, with higher scores consistent with poor health status. There's 3 sections. The first section measures symptoms, and it uses a 5-point rating scale, or Likert scale. Sections 2, activity, and Section 3, impact, use yes or no answers. And then missing scores are considered a no, which would suggest better health status. So how do you interpret this? It's considered extremely reliable and valid in chronic lung disease, including COPD and asthma. It is influenced by gender and age, education, and comorbidities. So what change is considered to be clinically significant? Change of 4 points. So it's the change you're looking for pre- and post-pulmonary rehabilitation in your population. Next slide, please. So the second tool I'd like to talk about is called the Chronic Respiratory Disease Questionnaire, also a tool that's commonly used in research. There's 3 versions, so a little bit tricky. There's an interviewer-led, there's a self-report, and there's a standardized self-report. So why did I highlight self-report? It's the cheapest. So Joe Williams out of England is the person that would be the contact for that. And the reference at the bottom in red should give her contact information. So it's used to recall the 5 most important activities causing dyspnea over the past 2 weeks. Now, importantly, you need to check this after the patient writes it, because I've had patients that would only identify 2. So try to get them to identify the 5 activities. So it's got 4 domains. It has dyspnea, fatigue, emotion, and mastery. So you would score the total amount, but each subscale also has a score. So to interpret it, it measures physical, functional, and emotional limitations. It is sensitive to change in bronchodilators, but not really clearly sensitive to long-term disease progression changes. There's 20 items, and a change of 0.5 is considered significant for each domain. Slide, please. So this tool, called the Medical Outcomes Study Short Form 36 questions, this is by many considered the best known tool. In a rehab sense, where we see it often is if a program has both cardiac and pulmonary rehabilitation. It can be used for both. It's not disease specific. So it's generic, measuring health and functional status. It is responsive to long-term disease progression, however, less responsive in COPD because it's not disease-specific. It does have a scoring algorithm, so when you purchase it, you would need to get the scoring algorithm to score it. And I should back up and say you also need to get the scoring or you should request the scoring algorithm for the St. George Respiratory Questionnaire. Apologize for not saying that earlier. To interpret the tool, you would score 2 main areas, physical function and mental function. And you can see on this slide what components make up those 2 areas. It is a norm-based tool. It's considered valid, reliable, and sensitive, but no change or specific change value has been established. And on this slide is the resource for getting the tool, but this is the link is easily available on the internet. So the SF36 is the common term that we use. It has had much wider use than the SF12, although the SF12 has been used in some rehab settings. Next slide, please. So the CAT came out a few years ago, again from Paul Jones, the same author as the St. George Respiratory Questionnaire. It is valid in COPD and pulmonary rehab. It is part of the GOLD guidelines for COPD assessment. There's 8 questions, and it's a 6-point rating scale, and the score ranges 0 to 40. So this is an easy tool for the patients to complete and understand. Higher scores are associated with greater limitation, and there's ever-increasing validation of this tool, and it certainly is simple from a scoring, reporting, and patient data, patient completion standpoint. Next slide, please. So the Ference and Powers Quality of Life Index, or QLI, this is available on the website in a pulmonary version. You can see the URL at the top of the screen. It has 5 scores. I should say it's available in several languages. The total quality of life, and then 4 subscales, specifically health and functioning, social and economic, psychosocial and spiritual, and family. So their patients ask how satisfied they are of 36 items and how important those items are. It's free to persons that are performing nonprofit research and clinical practice, and all are available on the website. There is scoring instructions available on the website as well. Slide, please. So this is the Dartmouth Primary Care Co-op charts. Really interesting take on measuring quality. Health-related quality of life. So those of you that are familiar with the 7 phases of pain would understand this concept, and it may have some particular usefulness in patients that speak English as a second language, because it tends to have pictures that are associated with descriptors. So it's a generic functional status measure. It's originally designed for primary care. It's available. It requires a one-time $100 fee for camera-ready charts, so you copy the charts and use them as your tools. It's either self-administered or interviewer-administered. It takes about 4 minutes to complete. You would use between 6 and 9 charts depending on your choice and your goals. It measures physical and emotional findings, ADLs, social activities, support, health, pain, and quality of life. So it's a 5-point Likert scale, pretty straightforward to use and score. The chart indicator focuses on the function in the specific domain. They don't encourage summing all of your total scores because each domain is different, but it can be summed if you're doing research. So again, this is available if you do a search for the Dartmouth Primary Care Cooperative CO-OP charts. You'll get all the information and updated, and this is the contacts email, Deborah, deborah.j.johnson@dartmouth.edu. Next slide, please. So you can see by the examples here, each of them come with a descriptor of the domain that's being evaluated. So for patients that are again having trouble with a lot of text, this might be a consideration. Next slide, please. So this is a chart that just gives you some comparison about quality of life tools. It compares just 3 tools, the St. George, the CRQ or Chronic Respiratory Questionnaire, and the SF-36, how many items they use, how it's administered, how long it takes to complete it, what does it measure, how many points, and if there's an MID, how to score it. So it just gives you a comparison of what the tool offers for you and your patients. Next slide, please. And then before we go on to psychosocial, I'd like to tell you who's using what. So St. George Respiratory Questionnaire, 16% are using. The CRQ, again, 16% are using. The CAT, 26% are using. The Ferens and Powers QLI, 6%. The SF-36, 1%. And the Dartmouth, 7%. Others, 29%. So there is a range of different tools being used. So I'd like to turn to psychosocial tools, and I'm going to talk about a few different tools. The Geriatric Depression Scale, which comes in a 15 or 30-point version that's free of charge. The SESD and the PHQ-9, both free. The Hospital Anxiety Depression Scale is licensed, as is the Psychosocial Risk Factor is licensed, and the Beck Depression Inventory is licensed. Next slide, please. And I bet you knew this was coming. Which measure of mood disorders do you use? So I'm going to give you a few minutes to respond. And this actually just looks at 6 tools. Geriatric Depression Scale, either the 15 or the 30-point, SESD, PHQ-9, Hospital Anxiety and Depression Scale, and Psychosocial Risk Factor Survey. Next slide, please. Okay, so Geriatric Depression Scale. So this, again, has 2 levels of amount of questions, and I've listed on the right-hand panel the different questions that are asked, or just a kind of a flavor of what's asked. These are yes or no responses, and you can kind of get a sense by looking at these questions These would probably not be too hard for an elderly person to answer yes or no to. So in that sense, it's easy to use, easy to administer, easy to score, and the only limitation, some of you may be familiar with something called the DSM-5. It is the manual for accurately diagnosing psychosocial disorders, psychological disorders, including depression. And defining depression has specific criteria, including suicidal ideation or thoughts of self-harm or suicide. That is not included on this scale, so that might be a limitation for your population. Globally, whatever tool you're using, you need to have a policy in your department of what you do if you get an abnormal finding. And this will give you in a highlighted version where the abnormalities are scored. All these tools have cut points of where what suggests significant depression. So you need to report significant depression, severe, moderate to severe depression. You need to report new depression, and you need to immediately report any suicidal ideations or thoughts of self-harm. I can tell you what we do. We fax and we call the physician, and I talk to the patient, and we get a confirmation that we've talked to the physician, and then we measure them halfway through the program to see how they're trending. And we talk to the patient about depression and, that it's important, it's painful, they're suffering, it is treatable, it requires evaluation, and can respond to treatment and can improve with pulmonary rehab. So it's really a message of importance, but also some hope of improvement. Next slide, please. So the Center for Epidemiological Studies Depression Scale, this is the second tool. It measures symptoms of depression in the community. It's a composite of 4 different scales. It does include actually many features of the definition of depression. It says it doesn't include appetite. It actually does. So it does include feelings of really being stuck and feeling low energy and low mood. It does not include suicidal ideation. It's rated 20 items, 0 to 3 scale, and this is the cut point for interpretation. So give you an idea of when you would report abnormality. There is no clear MID for the tool, and it is considered valid and reliable. And this is the URL for obtaining it, or you can do a search on the internet for the CES-D, and you'll find all the details you need. Next slide, please. So some of you may be using the Patient Health Questionnaire 9 or the PHQ 9. So this is what it looks like. It does measure all of the criteria for depression in the DSM-5. So it's an accurate screening tool or evaluation tool for depression. We can't diagnose depression, but we can certainly find out information about it and report it to so that the physician or psychiatrist, psychologist can accurately diagnose the patient. So if you look at the features, it looks at little interest, feeling down, sleep abnormalities, low energy, appetite abnormalities, feeling bad about yourself, concentration problems, either moving so slow or moving so fast that it's abnormal. Question 9 is a big deal. Any positive response to this needs immediate reporting and documentation. The only tricky part I have with this scale, if you look at how it's rated, 0 is not at all, and then you jump to several days. So that can be a little tricky, but the scale is globally used, very well validated, so it certainly has its strengths. Next slide, please. So it's self-administered version of the PRIME-MD. It's, again, consistent with the features of the validated definition of depression. It uses a Likert scale or rating scale, and this gives you the cut points for abnormality. So moderate depression and on up, you do need to report, or any change in depression. And absolutely any positive response to question 9 has to be addressed quickly. And obviously with all of these tools, when the patient gives you their questionnaires, look at the mental health questionnaire the first day. You don't want to miss abnormalities that are important. It is public domain, considered valid, reliable, and sensitive in elderly chronic lung disease. A 5-point change is advocated as a significant change. So that could be your goal, is in your population, you would look for a 5-point change. It's a little tricky, so if they're starting at 0, you're not going to see that. So you may want to see patients that have at least a 5-point elevation in score to try to look for change. Next slide, please. So I'm sorry that this is cut off, but whoops. Oh, okay, sorry to have a technical problem. So this slide, I'm not permitted to give you the whole scale, but I wanted to give you a flavor of what it looks like. So this is the Hospital Anxiety and Depression Scale. It's a self-assessment scale for depression and anxiety. Next slide, please. So this is a self-assessment that uses 7 anxiety and 7 depression assessment questions. It's scored on a 0 to 3 scale. And to interpret it, it basically looks at psychometric properties as a self-rating instrument. It's considered valid and reliable with factor structure and intercorrelation. It's got subscales that are valid measures of severity of emotional disorder. It does require a licensed agreement, and there is no specific number or change that's considered clinically abnormal, or clinically significant, I should say. Next slide, please. This is the psychosocial risk factor survey, and this looks at many features of mood disorders. It's a 70-item question, the only survey developed for pulmonary and cardiac rehab. So this gives you information about it. It's available from deltapsychologycenter.com, and they'll give you all the details. Next slide, please. And this is the BODE index. I'm going to go ahead because I want to be sure we have some time for questions. The BODE index is a composite score measuring nutrition, FEV1 or obstruction, dyspnea, and exercise using the 6-minute walk test. And it's well validated in measuring change in COPD, particularly in lung volume reduction surgery, pulmonary rehab, and physical training. It is a good predictor of mortality, exacerbations, and readmission. Next slide, please. So how do you choose? Look at what is right for your department, how much money you have, how much time you have, and how much complexity you can deal with. Include your team. If a tool isn't working, consider another tool. Next slide, please. So the registry we talked about earlier. Next slide, please. So this is really what the registry does. It allows you to enter all of your outcome information as well as clinical findings and demographics, and it gives you back that information in a format patients, referral sources, and you can use to consider your impact and make improvements over time. Next slide, please. This is an example of the report that you would receive. Next slide, please. Some resources for you. Your important resources include ATS, AACVPR, and ACSM. Those are the 3 primary resources, and then the GOLD guidelines. Next slide, please. And I want to thank you and open up for questions.
Thank you, Chris, very, very much. We do have a few questions. I am going to start chronologically with some questions that were asked at the beginning of the presentation. A couple of our attendees wondered how far apart can the 2 initial 6-minute walks be? Can they be on the same day, on different days? Should they be weeks apart? Is there a guideline for that?
It can be on the same day, and normally the recommendation is approximately a 30-minute rest in between the two walks. So yes, it can occur on the same day. You might want to have the patient fill out their questionnaires in between the two walks just to fill the time. Good question.
Wonderful. And then another question about the 6-minute walk. Do you ask about pain and dyspnea at the 3-minute mark while the patient is walking?
No. So the recommendation or the statement recommends you check it at the beginning and you check it at the end. So the only thing that is checked during the walk in terms of recording is the lowest oxygen saturation rating. If they stop at 3 minutes and they don't resume to finish the walk, you would have to say, okay, the maximum shortness of breath you felt during the 3 minutes you were walking.
Wonderful. And another question about the actual evaluation scales. Can you explain to us the difference between the Borg scale and the modified Borg scale?
Great question. So the Borg scale, what I've seen that really struck me as different is, it's got a descriptor for each item, and for the Borg scale, number 5 is strong. And those of you that use the modified Borg, number 5 is severe. I've always had issues with that, thinking, well, if 5 is severe, what's 10? So Dr. Borg has got, I think, a good point about really trying to specifically ask for what you're wanting to hear. And what the patient might be able to understand. It's actually been, as I said, it's been tested and validated, whereas the modified Borg scale hasn't been tested and validated by Dr. Borg. So, yeah, that's the main difference is the descriptors. But he's got some fine details for consideration of use that I think would be helpful to review.
Fantastic. Another question that we have, which was based on your not the last polling question, but the second polling question that you had about, I am wrong, the first polling question you had about the kind of scales that you use. One participant wondered why the Beck Depression Scale, I guess it is the last question, why the Beck Depression Scale was not a choice on that last question.
Yeah, I apologize. I was concerned that we wouldn't be able to get all the tools in, so it wasn't, and I'm sorry for that. For those of you that are curious about the Beck Depression Inventory, it is licensed, and it's, I think, rather similar to the PHQ-9. I've used it a lot in sleep disorders, very easy to use, and very good at capturing symptoms. So, again, I apologize that it wasn't included.
Thank you very much. And now I have time for one more question. So this is going to build on that depression scale. Are all certified rehabs required to have or use depression assessments?
Yes, that's a great question. In fact, Medicare is specifically looking for psychosocial symptoms. So absolutely for certification, it is required. So that's a great question. And you might ask yourself why. Well, you look at people with COPD, 40% have clinical depression. Like COPD, it often goes undiagnosed and untreated. So it's an opportunity for us to help the patient to identify their symptoms and alert the physician that they have abnormal findings and should be evaluated and effective treatment should be offered. That's a great question.
Chris, thank you so much for joining us today. This was a fantastic presentation.
Thank you. My pleasure. And thanks to all of you for taking time from your busy day. I hope this has been helpful, and if you're an ACVPR member, you're welcome to send them questions, and they can route them to me. I appreciate you taking the time, and thanks for all the effective care you're providing to your patients.
Thank you again, everyone, for joining us. Please join us on Friday, August 19th, when the Respiratory Care Journalcast return with the August Editor's Choice with Mr. John Gallagher. Also join us for a special webcast on Wednesday, August 24th, when Mr. Carl Hinkson discusses current evidence in APRV for trauma patients. Thank you for joining us, and have a great day.
Great, and that is all the time we do have today. I want to give a huge thank you to Chris for sharing her expertise, and also thank you to all of our participants for your engaging and interesting questions. In just a moment, you will see a Submit Credit button appear on your screen. If you are an individual who's registered for this program, you will go through the credit submission process on your individual account. Should this button not appear, please navigate to the Credit tab and select the Click Here button linked. If you are a group participant, please have your group leader submit your information to the Group Attendance tab to be provided with follow-up instructions on how to submit for credit. This does conclude today's presentation. To end, simply exit out of your browser windows, and we hope that you have a great afternoon.